Good evening, everyone. Respected Dr. Pradeep Shetty, sir, respected members of IADPE, and my dear colleagues. It is my privilege to welcome you all to yet another episode of Learn from Our Master series organized by the International Association for Dental Practice Excellence. The successful completion of more than 75 webinars stands as the testimony to our collective commitment towards academic excellence and continuous professional development. We sincerely thank all the doctors who have consistently participated in our webinars and have supported us through our academic invitations across our social media platforms. Your encouragement and constructive feedback inspire us to continuously elevate the quality of our educational programs. For the benefit of participating joining us for the first time, allow me to briefly introduce our organization. The International Association for Dental Practice Excellence is an academic platform founded on the principle that quality education leads to predictable and reproducible clinical outcomes, irrespective of specialty or experience. Recognizing dentistry as a dynamic and ever evolving science, IADP is committed to providing structured educational programs through webinars and hands on workshops that strengthen clinical competence and professional confidence. Without further delay, we shall now proceed with today's session of the Learn from Our Master series, wherein the topic for discussion is Glossy is Classy, Anterior Composite Concepts. It is indeed an honor to introduce today's distinguished speaker, Dr. Pradeep Shetty sir, holds a master's degree and doctorate in consultative dentistry and endodontics, currently serves as the professor and head of the department at Dr. D.Y. Patil Dental School, Pune. With over 2 decades of extensive clinical and academic experience, he is a key opinion leader for Oricam Healthcare India Limited, and Dr. Shetty has delivered numerous national and international lectures and workshops and has trained more than 1,200 clinicals through advanced hands-on programs in endodontics, aesthetic dentistry, digital dentistry, and restorative dentistry. He also heads Imposition Dental Care and which has 20,000 patients with a dedicated team of consultants. Without taking much time, I now invite Dr. Pradeep Shetty sir to kindly commence today's academic celebration on anterior composite.
Yeah, good evening.
Good
Thank you
evening,
so
Dr.
much. Yeah, thank you so much for the introduction. I'm Dr. Pradeep Shetty. I'm from Pune. I'm basically a clinician and academician. Today, through this webinar, I'll try in this 1 hour, I'll try to explain a basics concept with the modern touch of anterior composites. So we all do anterior composites day-to-day clinical practice. And sometimes what happens, you feel sometimes what happens if you are maybe you will be lost, or sometimes you may not be knowing exact method of doing. So I'll try from the beginning, from the scratch. I'll teach you, and I'll show you some clinical videos, and it will be helpful for your clinical practice. See, when a patient comes to you, what happens? I request all the participants to kindly mute.
कोई आदमी के सीखे का अलग होना चाहिए।
Yeah. Okay. Now, can you hear me? Yes. Now, yes. So now when the patient comes to you, so what happens when the maybe patient have a simple problems like class 4 restorations or a broken tooth, or sometimes there is a small space in the tooth, or sometimes it is a extensive smile designing cases. So before we do any smile designing or any anterior restoration, certain things we have to consider. That's called as four aesthetic theories. So whenever patient comes to you, for example, a patient comes to you for any smile designing, okay, for a veneers, you want to give a veneers, or sometimes we want to give some close the diastemas. So we always judge the patient before doing anything by drawing a treatment plan. So that is a treatment plan always considers four types of aesthetics. That is facial aesthetics means what? When the patient comes to you, you always speak to the patient, you understand their problems. Okay. So if they are coming with the problem of any smile designing or any restorative anterior restorations, so then your aim is to observe lip line, soft tissue curvatures, smiling, laugh, or a speech. How much? Because it gives because smile designing is absolutely a proper treatment plan. If you don't have the proper treatment plan, then it'll become a disaster. If it is a proper treatment plan, then it will be very successful and you will feel the happiness on the patients. So that is the reason you have to first you think how much you required, what exactly the problems of the patients, and how much if the patient is telling that patient is smiling, only canine to canine is visible. So it is no need of giving a veneers or anything to up to premolar or molars. Or patient is having a broad smile, maybe up to first premolar or second premolar, you may have to consider giving a veneers or any smile designing to extend more than canine. That is how the facial aesthetics. And then comes ginger aesthetics. Means what? Your vision becomes narrow. From the face to comes your ask the patient to open the mouth and start checking the gums health. Because gingival health is very important when you're talking about any cosmetic procedures, especially veneers, or if you're doing any diastemas, or if you're doing any anterior composites, which is involving near to the gum line. Because what happens, composite will be placed upon the tooth surface, and there will be a small gap between the composite and the gums. So if the health is not good, the food lodgement occurs. Already there is a plaque accumulation. Already there is gingivitis, periodontitis. It gets worsened. So you'll check for the gingival aesthetics. Then comes macro aesthetics. In the sense, you check for the tooth itself in a broader way, like midline. How is the size and shape of the tooth? Whether tooth is like they have a any lateral incisor is smaller, central is bigger. What is the proportion of the tooth? Is it in a golden proportions, or you have to get into the golden proportions? All these things, and again, because this is from I told you, it is from the broader to the narrower. Now you are coming to the last portion, that is your micro aesthetics. Now, if you are thinking for doing a class 4, so if you're doing a class 4 restoration or at least class 2 fracture, where enamel and dentin is fracture, pulp is not involved. So you see the teeth, whether the other portion of the tooth, whichever remaining, or a adjacent tooth, how the tooth looks, whether tooth has mamelons, whether tooth shows any lobes, or whether tooth has a translucency, all these things. Your observation becoming is more and more micro, or a more and more narrower, or more and more tooth specific, or each micro characteristics. So that is how the you have to draw a treatment line. Okay. Then comes your composite buildup. Then you have to start building you did a treatment plan. Maybe you are going for a composite, because this topic is majorly on a composites. So we stick to the composites. So now you thought that I'm going to do a composite restorations, maybe a simple one fracture of the tooth, or some angle buildup, or you may going to do a diastema closures, or you may have to do a composite veneers. So this all comes as a anterior composite. More than this, there are so many other things like natural tooth pontics, or if you're doing a composite reinforced bridges, all these things comes. But for today's discussion, we'll limit ourselves to majorly to the fractures, anterior fractures, tooth fractures, or to some extent midline diastema closures. Okay. So whenever there are two components of anterior, composite adaptation and finishing and polishing. In my practice, I do composite adaptation or a composite build-up. Maybe in a more of simple class 4, I take around 20-25 minutes to half an hour, and I will take same amount for the finishing and polishing. So most of the time, what happens, I've seen my many clinicians, what they do, they take a lot of time to the composite adaptation, composite build-up, but they take a very less time for the finishing and polishing. Composite is nothing but finishing and polishing. Composite adaptation is very simple. You'll have to just adapt and go, just make like a tooth, somewhat it resembles a tooth, maybe sometimes over contoured, But the main is finishing and polishing. If you know how to do a finishing and polishing, if you know how to do the tooth looks like a tooth, then it'll be easier, because we all learned dental anatomy. So dental anatomy matters here. If you have not done dental anatomy properly, you have done a carving from somebody else. You have submitted the carvings by somebody else did it, and you submitted in your dental anatomy practicals. It'll be difficult for you, because it's entirely about the dental anatomy, understanding the tooth structures, understanding how the tooth looks, and what is the patient's expectations, what you can deliver. Okay, this comes as a finishing and polishing. So whenever patient comes to you, when this is all the steps I have jotted down. Okay, whenever the patient comes to you, first thing is you'll have to take the impression. Because why? Because we in the beginning, some of you may be a beginners, so you have to do a mock-up, so that it will be a trial. Okay, you can take the impressions, or if you have a scanner, you do the scanning. And photographs are must. Okay, the major reason for the photographs is, one is for you to understand, so whether how the tooth was looking earlier and how the pre-op and a post-op comparison. Second is to improve yourself. So you have done some fillings, and today by the photograph you can see that I would have done it better. Or sometimes you will improve it by yourself, or to show the patients, see, your teeth was looking like this, I have done like this. Or to show to some other patients for convincing. Okay, so I have, this is the case which I have done. This looks like this. So you will be, if you do for you also, it'll look like this. Because we all did the same mistakes in our early practice. We have never documented. This is one of the major problems with us. We don't document. We do take the case sometimes. Once you do a post-op, then you will understand that, oh, I would have taken a pre-op. Today we have good mobiles. At least you do a mobile dental photography. If you have a DSLR, it is well and good. Wonderful photographs you can do. Then you do the mock-up, and you do the putty index. I'll show you steps by one. Okay. Then do the shade selection, do a rubber dam isolation. Most of the time, anterior composites requires a rubber dam isolation. Okay. This is mandatory, so that it is adhesive dentistry. Adhesive dentistry does not like saliva contamination. Better to do isolation. And very important is bevel. Okay, I'll teach you how to give. I'll show you how to give the bevel. Bevel has to be perfect. It has to be primary bevel and a secondary bevel. Then, if it is going very deeper, if it is a Ellis class 2 fracture or any caries approaching to the pulp, it is mandatory to the pulp protection. Otherwise, what happens? The patients may have a sensitivity. Okay, then you have to have a proper etching and bonding strategy. You have to have a proper metrizing and composite application with the proper composite filling instruments, and initial finishing and polishing. And remember, you have to call the patient for follow-up and finishing and polishing after 24 hours. Because what happens, whenever you do the tooth build-up, whenever you start doing the tooth, it is always, you do it in a dehydrated state. You remove all this, because there is no, you remove the water entirely from that. So the area is completely isolated, where there is no question of saliva comes into it. So when you adapt the tooth in a dehydrated state, when the patient goes home, when patient is saliva, when comes into contact, or patient has food, there will be a tooth gets hydrated, and same time composite also gets hydrated. After the hydration, it should match. Okay, many times what happens, sometimes it won't match afterwards. So that is the reason for, you'll have to do the 24 hours afterwards, you do the final finishing polishing. So this is the step. First thing, you have to take a photograph, proper photograph, with cheek retractor, with sometimes with the you will have to go for a black background, so that it looks nicer. Okay, then you take the putty index, or if then you do the mock up in that. Okay, then comes shade selection, because we all know that shade selection, we learned in our first videos or second videos. Okay, we never learned about hue, value, and chroma. We just, it's gone. Okay, sometimes what happens, in the beginning, you don't understand dentistry much. So it is taught in a very beginning phase. So you never understood hue, chroma, and value. It is very important in a cosmetic dentistry or any composite dentistry. Understand. Well, I'll just briefly help you out to understand hue, chroma, and value. Hue is nothing but basics colors. So whichever the color you have, maybe you are wearing, everybody is wearing some type of dresses. Maybe they may be wearing a red dress, green dress, blue dress, yellow dress. These all basics colors are called as hue. It is world has lots of color because world does not have a colors. Actually, it is a color is nothing but the light perception. Okay, the light comes, whatever the light comes, it is, if you don't have a light, if you go to a dark room, whoever sitting in a, whatever the color they are in, it looks darker. It doesn't, you don't see anything. When the light comes on particular person, the color visible becomes visible. Okay, that is a basic. Hue is basic color. What is chroma is concentration of that color in that particular color. Suppose I'll give you an example. If you have two buckets of water, so in one bucket you have given a two drops of yellow, in another bucket you have given a two drops of blue. Okay, so blue and a green are both are hue, and two drops you're placing, that is nothing but the chroma, that is the concentration of the color. If you place a blue, if you place three drops of blue, so the saturation of the color is increased in blue. So there is a three drops. So saturation is increased. This is nothing but the chroma, the color saturation. So if the saturation is more, color becomes intense. If the saturation is less, color becomes little dull. Okay. So what is the value in that? Value is nothing but darkness and lightness in that particular color. So I will give you example of same thing. I have taken a two buckets of water. In one bucket, you have 1 liter, 1 liter, both have water. And in one bucket, you place four drops of yellow. In another bucket, you have placed four drops of blue. So when you see this particular color, both have different hues. One is yellow, another is blue, but both have same concentration of the color. Here also four drops, here also four drops. Means chroma is similar in this bucket also, that bucket also. But when you see, look into that color, yellow becomes little brighter because yellow has the value, higher value. It is brighter in shade. Whereas your blue has lighter, darker value because it is darker in shade itself. It is darker. You must have seen black and white movies. So in Hindi, there is Devanand, Rajesh Khanna, and they are all, they used to have a black and white movies. Black and white movies means what? It is the color is removed. Saturation is zero. Okay. If you remove entirely color, saturation it becomes a black and white. So Devanand might be wearing a darkest yellow shirt, but when you black and white, it looks whiter. Devanand might be wearing a very lighter red shade. Okay, but in a black and white, it looks blacker. Okay, this is how the value comes. If you remove entire colors from the saturation, from if you remove, because as simple as if you take a photograph, make it as a black and white, remove the color saturation, that gives you a value. Okay, because for us, for patients, don't say that this color is like this, that they always say lighter or a darker. We always say lighter or a darker. Means for us as a composite restoration, value is very important. We can say we value the value. Okay. So now this is a shade guide. This is in a shade guide. We have 16 shades. We have a red, yellow, gray, and gray red. So red yellow is nothing but this is the, what is this? This is hue. Correct? In this A1, A2, A3, A3.5, A4. This 1, 2, 3, 3.5, this is nothing but the chroma. Okay. And if you see this, A1 and a B1 and C1, they are the brighter. Whereas your A4, B4 and C4, they are the lighter. Means value of C4 is lesser, value of A1 is higher. Like that. It goes like that. Okay. Now we can say that A is the hue, A1, A2, A3 is the chroma, and the lighter and darker shade is nothing but the value. So if the value is zero, it becomes translucent. It looks like a glass. Okay. If the value is less, then it is become darker. So that if at all, if you want to merge something, we say is opaque. Opaque is nothing but it is a whitest shade. So if you have a glass, if you don't want to see outside, what you do is you place a opaque or you place a black film. So both the times you cannot see outside. Same thing. If you have a low value, okay, or you have a high value, both the shades can be used to mask the underlying shades. If you have any if you want to mask something, you can place a opaque so that it gives a. So you must have seen in a PFM crowns. In the PFM crowns, to mask the metal, they put a opaque. So opaque is the whitest one, so that it masks everything. So sometimes in a 3M shades, they have a dentin shade, which is darker, okay, which is kept near the pulp, like that. So if you see, like here, we have arranged the Vita shade guide according to the value. You can see that B1 has the highest value and C4 has the lowest value according to the value. So now, how do you understand? So in a clinical scenario, when the patient comes to you, before cutting anything, you do the shade selection. So you place the buttons like this. I'll show you. So there is a patient comes, you do the shade selection. Use your shades in a button shade. Okay, you can place the buttons. Okay, and margin of the button should be little more. It has to be little arranged on the tooth surface so that it should merge with the tooth. So various shades, whichever it is nearby, which you have find and cure it. Okay. Once you cure, why you have to cure? After curing, light becomes changed. Once you cure it, you take the photograph. In the photograph, what you have to do is, so there is, you can see that there is in a phone, there is one edit option. There is a color saturation. If you make the color saturation to 100%, then it becomes a chroma. If the color saturation is completely minus 100, it becomes the value. Okay, so that is how you can understand the tooth value and a composite value is matching to each other, or tooth chroma and composite chroma, whether they are matching each other. So you change the saturation, either minus 100 gives you a value, to the plus 100 gives you the chroma. Then once the shade selection is done, you place the rubber dam, okay, then start giving a bevel. Bevel has to be given. There are two bevels should be given. One is primary bevel. Primary bevel has to be given at the margin like this here, at the margin. Okay, this is a tooth surface. This much is tooth is broken. And the literature says that all the studies that your secondary bevel has to be bigger than the tooth surface which is lost. Matlab, this much tooth surface is lost, your bevel has to be this much. Your secondary bevel. Secondary bevel has to be bigger than the lost tooth surface, because it is because many clinicians says that I've done a composite restorations, but I can see the demarcation line. You can see where is the composite and where is the tooth. So demarcation line majorly comes because of the less bevel. If you give a more bevel, nice bevel, then the demarcation line becomes less. So primary bevel has to be given like this. Secondary bevel is just roughen it, roughen the surface. In some cases, if the tooth is having tooth wants more retention or a frequent fracture of the restoration occurs, then you give a sunburst appearance. Means you give a small grooves. Okay, bigger and a small grooves, like how you draw in a childhood. Sun used to draw like this, right? Small and bigger, like this, right? Like that grooves you give. And by giving the grooves, one is your demarcation line will be, you can mask the demarcation line. Second is, you are giving a more surface area for the bonding. The more the surface area, better the bonding. If you have done only this much bond, if you have done only this much bond here, only this much, if the patient goes and have small food also, this may come out. When you give a bonded till here, so it has adapted the tooth like this. It has gone here and it is gone here. It has adapted the tooth in such a way that it won't come out that easily. So this is how you give the bevel. Okay. See, I'll show you in my clinical video. You can see I'm giving a primary bevel. Okay, here, and remove all the unsupported enamel. Remove the all unsupported enamel. Okay. Then inside also you give a primary bevel. It is very, very important. Most of the time people don't give a bevel on the inside. So give a bevel on the inside, and then secondary bevel on a surface of the tooth. This is how the sunburst appearance you can make it. Secondary bevel has to be given on the surface of the tooth, maybe till the half of the tooth, because tooth is broken half. Okay, this is how you give the bevel, primary and a secondary bevel. It is very, very important for composites. So there are a lot of articles which says that which bevel should be given, what bevel is better. Okay, this bevels has to be perfect. Otherwise, what happens? If you don't give the bevel properly, it is going to your composite may come out, or composite. You can use the burrs, which is you can always use tapered burrs, especially tapered burrs. I've showed you. The tapered burrs has a better not very, very thin tapered. Okay, it may be TF11 or a TR11 or all taper buds you can use it. Then, as I told you, pulp protection. If it is cavity is very, very deep, it is better to give a pulp protection by light pure GAC, or sometimes you give a 7th generation bonding agent, not to select do the selective etch. Only etch the enamel surface. Don't touch the dentinal surface. Do the selective etch and use a 7th generation bonding agent or 8th generation bonding agent. Rub it, modify the smear layer, and do the pulp protection. If it is very, very nearer, if it is for a liner has to be given, then you can give the empty liner or a GIC base. Okay, it depends how much is the RDT. Then very, very important is acid etching. Most of the time, we are coming into the generation of universal bonding agents where the bonding is there universal. It can be etched and bonded. Most of the time, we preferably use enamel. We etch, and the dentin we don't etch it. Enamel is always etched, and so selective etch. It's called as selective etch. Total etch is only do when if the cavity is only at the it is not in the dentin. It is just in a superficial of the layer of the dentin or in the enamel. You always go for a total etch. Okay, you etch entire surface. If the cavity is inside the dentin, a deeper layer of the dentin, it's better to do a selective etch. Okay, and you have to have a good matrices system. BioClear is one of the very good matrices system which can be used, but BioClear becomes sometimes expensive, or there are some other matrices you get it like there are online platforms or in somewhere in the trade fairs and all, you get like this matrices, like a spoon shaped matrices or a unica type matrices. This can be used. This is very, very useful for the composites. I'll show you some clinical cases where I've used this metal matrices so that it can be adapted nicely. If you have a BioClear, it's nothing like that. And you have to have a good composite instruments. I use a lot of instruments in my personal. I use Optrasculpt a lot. It is one of the very good instruments from the IVUCLA. It can be used, or you have to use there is Style Italiano. So instruments are there. They are also very, very good instruments. GDC also has certain good instruments like I have showed you, and you can say you at least you should have a Teflon coated instruments which is coated, so it should work nicely. And you have to have you can use applicator tip very nicely. You can make use of the applicator tip to adapt the composite, or you can use the brushes, okay, for the composite. This is the armamentarium for a composite application which I use. And I have a lot of composite finishing and polishing. I have every company's finishing and polishing, starting from Densply has a Pogo, Ivoclar has a Eve, and Softlex from the 3M. Okay, they have spirals from the 3M. Shofu has Super Snap Kit, and 3M has again they have finishing and polishing strips, coarse, medium, fine, super fine, and this is all the things I use for the finishing and polishing. It is very, very important. As I told you, I take more time for the finishing and polishing than the adaptation. Okay, I'll show you a case. There are two clinical scenarios I showed you. I'll show you. This is a clinical scenario where I've done a freehand technique. Okay, I'll show you how to do. So this is the case. I've done a. You can hear my voice, right?
Yes, doctor.
Yeah.
Yeah.
Okay. So here I've done I'm giving a bevel. You can see, remove all the unsupported enamel here. Okay. This I have done without the putty index. Okay. This you can do it if you are experienced. Okay. If you are doing in a initial, it's not a classic method. Classic method is a putty index. But what happens sometimes patient comes to your case on a OPD basis. So you don't have a time for the putty index. You have a lot of patients. You will have to do a freehand techniques. Freehand techniques also good, but it is technique sensitive. If you should be very good with the adaptation, and you should know understand the tooth. Here I have applied a plumber tape, that is PTFE tapes. Okay, so that you can apply it so that the adjacent tooth will not be etched. Then you do the bonding. Okay, I did a selective etch. Okay, cure it, 7th generation bonding agent. Okay. use a good light curing units. I'm going to tell you that use a good light curing units, because what happens if you are a composite, it's not a sometimes it's not a problem of a composite. It is problems of the sometimes your light curing unit. Okay, you have to have a good light curing units. It has to have a proper depth of cure. Otherwise, what happens? Only superficial layer gets cured, and inside it won't be cured. Okay. So nicely place the matrices inside the circular area, okay, and adapt to the matrices. So I don't use much of a mylar strips, because sometimes what happens, mylar strips adaptation becomes very difficult. This is a tooth shaped, or matrices are very anatomically positioned. So tooth anatomy, it's very easy to get it. In a mylar strips, you have to make the anatomy, tooth anatomy, because there are striped strips. See, I'm adapting it. Okay. When you adapt it, you have to adapt it little by little. More than that, you need not put it a lot of what do you say? You need not do much of a contouring. Okay, you'll have to just understand the tooth anatomy and adapt it. So don't think about the carving here now. You just adapt it. Okay, it should be little more. Okay, you should not apply less. Okay, so that you have a space for the reduction. Okay. So I'm using a yellow band burrs for the reduction. You can use a yellow band burr also. You can use a blue band burrs also if you have a control over the burr. If you don't have a control over the burr, if you feel that you may over reduce, use the yellow band burr. Okay, they have a finer surface, so they don't cut much. Okay, so here I'm using a Softlex for the course. Okay, initial. Okay, I usually use Softlex course grids for the initial course finishing. Then I'll go for a slightly go to Eve. Okay, then change into Eve spirals. Okay, then here I'm using only one system to show you. Here the Softlex has coarse, medium, fine, and superfine. Coarse for the contouring, and a fine and superfine for the finishing purpose. Okay. Here I've used the interdental strips from the 3M again, Softlex interdental strips. Okay. So this is after the finishing and polishing. You can see nicely adapted. And whenever you do the any putty index method, okay, this is all the steps. This is always repeatable. It is like this only. So you do the putty index. First is a palatal shelf. You do the palatal shelf. Okay, palatal shelf will be adapted to the putty and make the palatal shelf. It gives you a complete plate of palatal so that you can put a material on top of it. After the palatal shelf, what you do is you'll have to place the dentine and a body as a main shade. It can be placed on a primary bevel and it covers the secondary bevel. Okay, so you can place it like a dentine and a body shady, like a bevels or like lobes. Okay, you can do that, and then you can place a enamel or translucent shades in between. Okay, wherever the lobes are there. Then like that you have to adapt one by one. First you cover the palatal shelf, then you make the cover this all entire this area where you have given a bevel. Okay, like this you give a bevel. Okay, then after that in between the spaces which is left here, you can use an enamel or translucent shade, so it looks like a lighter and darker shade. It gives a proper lobes like effect. Don't, if the patient does not, it's in a younger patient it is required. If the patient does not have that translucency, if a patient is around 40-year-old or a 35-year-old, your enamel translucency becomes less. So don't give enamel translucency, it looks artificial. So give only one or mono shade or a dual shade and match it. It depends upon the patient teeth, I told you in the beginning. So how the tooth looks, okay? Accordingly, you'll have to do it. I'll show you a case. Okay, this is again a putty index. Okay, this is the patient came like this. So I done a shade selection and I'm giving a bevel. Same method, everything. Okay, did a putty index. Okay, did a etched. I did a total edge because it's in a enamel. Okay, then this dried it, then placed your bonding. Then I'm doing can you see the palatal shelf? Then I'd given what? The margins. I made the margins with the proximal contour. So now it is, you get a palatal, you get a margin of the mesial or distal side. Now what you have to do is you just have to fill it inside. Okay. So this is two portion you got it. One is proximal surface, other one is palatal surface. Now you got a box. So you'll have to fill the composite inside the box. As simple as that. Okay. And cover the complete bevel surface. Okay. Cover it a little more extra so that you have a space to reduce it. Okay. Now with the burr, it's very, very important is giving an angle. You have to give the angle. Never ever make the tooth flat. Tooth is never be a flat. It has a mesio labial angle, distal labial angle. Can you see that? Can you see the angle here? Okay. You can see the angle in the side, this side. Okay. Here you can see the angle. This angle is very, very important. You can see the angle here. So then when you give the angle, then only tooth looks nice. Okay. This is another case. Okay, you can see here. This is putty index, shade selection. Okay, so this is after the shade selection, I've given a do the bevel. Okay, same method. I'll just show you a little more. Uh, See, this is a after the parietal shell, you apply. Okay, apply nicely. Okay, same method, everything. Okay, this is the other matrix. Okay, this is a clear matrix. Okay, then remove the matrix once it adapted nicely. This is how. Okay, this is remove the excess. Okay, remove the excess. Finish it nicely with your soft flex or with other instruments. Okay, I'll show you other cases with other instruments. Okay, this is how. Then there are paint on colors available for if the tooth has any discoloration or any white shades. So this I had applied a paint on colors from the various companies you get from Coltin, Ioclar, and Tokuyama. Every company has. So see the final finish. I've applied I matched the entire tooth to looks like the adjacent tooth. So see, this is how the tooth has different gradations. So you'll have to go according to the gradations. As you go cervically, teeth are more darker. As it goes to the incisally, tooth becomes lighter. So your composite also have to have a gradations if the tooth are like this. Okay. See this again. You can see here in this case as well. See, there was a tooth. It's again I matched it, and you can see the angle. Okay. Angle should be there like this. It's a proper angle. If you see this, there's an angle here. Okay. And this angle should go like this and match this angle. Okay. Angle has to be bang on. If you don't have the angle, tooth looks like some roundish. So it does not look nicer. Okay. It has to have a proper angle. You can see, and tooth, you most of the time, what I have seen many people, they polish like a mirror. Tooth is never like a mirror. It doesn't have a flat. It has a elevations and depression. That is why we call it the micro characteristics. You can see here in this picture, you can see the micro characteristics here. This tooth and this tooth, you can see lines here. Okay, some elevations and depressions, minor elevations and depressions, exactly with the like it's the natural tooth. Also, if you see here, there is a elevations and depressions here. Okay, so same thing you should try to mimic it. So that is very nicely done with the Pogo. The Dentsply has Pogo Enhance. You can this is a diamond impregnated, very very good polishing and finishing systems. If you have a little more pressure, tooth has it has a coarse effect. If it is a less pressure, it gives you a finer effects. And here again, you can see, I have given a nice micro characteristics. Okay, see these teeth are nicely made and it is like a gradations of the shades. Okay, and always has this is how it has to very very important. Any tooth which has a tooth younger patients, maybe in a teenage patient, they have a mamelons. You can see mamelons can be there is a contra mamelons. So this is all you have to do with the shades, with lighter shade, darker shade. So you'll have to play with that. You can see there is a lamellas. Okay, you can see some halo effect. How do you do the halo effect? You give a the opaque one at the margin, and there will be if you give there is a like a halo, like opaque is at the round, and then the center is a translucency. It gives a wonderful effect. Okay, then there is a body has to have a dense, like you can see that is a fifth number is a body, here it is a dense. Okay, it should match the tooth like this. Okay, then there is in a enamel, it has a translucency here like this. So younger patients has a translucency, but it is only with the younger patients. This is my case. You can see here. So nicely, I had given a translucency. I had given a halo. You can see here there is a halo. There is a translucency. I had given a micro characteristics. This is how the tooth looks, and you can see you have to have a proper so you have to have that understanding of the tooth. You have to have the understanding of the anatomy. You should try to reflect what is the nature, what is the how the nature has given to us. It's a restoration is recreating the lost one. Recreating is if the nature has given a some tooth has a different shades, you try to recreate whichever whatever it is lost. Okay, you can see. So this is how the cases. Then you can see this. I've done a value check, A1, A2 shade. I've used the Vinci Smile composites here. I've given a bevel, primary and secondary bevel. Primary bevel is secondary bevel is bigger, and then shade, etched it and bonded. You can see while bonding, I'd kept a spoon-shaped composite that is a matrices. Okay, so that adjacent to the one be bonded and applied more. It's an over contour, then started reducing with the contouring with the gross finishing with the yellow band bar. Then I used here Eve for a final finishing and softlex. As I told you, I use both two. There's Eve and softlex for the gross finishing or a finishing purpose. Then I use medium and a pogo for the finishing purpose or a mid finishing. And the last is I use a again this Eve has two. One is gray grid, so that is for the it gives a glossy appearance. Or you can use the softlex spirals. Okay, it gives this when you use the pogo, so you can make the characterization, you can make the elevations and depression. This is how the my I use various systems of various companies. Okay, and at last we have to use the finishing strips to so that never ever join the two teeth. So the god has never joined the two teeth, so we should not join it. So we it has to be separated with a simple with your matrices or a you have to use the matrices properly and use the interdental polishing and a finishing strips. This is the final finishing. Okay, and this is how the pre and post operative looks with the proper incisal translucency. These are all the cases, is all the same protocol, same method. Okay, there is here I've used ampules. There are ampules are available. Ampules are very good. It is more hygienic and more perfectly can be used. And give a bevel, give the etching and build up. I use the Optra sculpt here. Okay, and the finishing and polishing. This is the final post-operative. Okay, there's another case here. Again, the same thing, same method, same primary level, same action, sectional matrix, bonding agent. Okay, this is all the cases which I'm showing you. I've used ampules here again. There are ampules, there are various viscosity available. There is low viscosity ampules are there. There is also low viscosity in the sense they're in a packable but very moldable. It can be nicely moldable. So you'll always ask for the viscosity. Initially, only packable and flowable was there. Now packable has high viscosity and packable has low viscosity. Okay, even flowable also has a high viscosity flowable and a low viscosity flowable. So this is the cases. So you can see everywhere why I'm showing these cases. You can see the angles bang on. Okay, if you see this angle is very all the right reflects here. Okay, this is I always stress all for every my students same thing. Give the proper angle. Here in this case, I digitally modified it. I've showed the patient that how it looks. Okay, can we have there are softwares for the digital modifications. This is a final finish. This is another case of very interesting case. The patient has a lesser. You can see the clinical crown is seen less. Okay, anatomical crown is bigger, so there is a proper gum band was there. This patient wanted a composite restorations, didn't wanted a veneers because every patient cannot afford veneers sometimes, even if you want. But in this, if you do a composite, patient wanted to close the diastema spaces. But if you do just close the diastemas here, tooth looks wider. Okay, because there is a differentiate, there's a golden proportion or a golden percentage or a red percentage. All these things are gives you the height has to be more than the width. The width has to be around 70 to 65 to 75%, and 73% is considered to be the ideal. It has to be, it can be a 68 to 78, around 70% comes in between. So here So first thing is I have to correct the zenith. Okay, if you want to, I want to increase the length. So what I do is I will increase the zenith. I will do the, because I cannot increase the incisor length. If you do the incisor length inside, tooth will look odd, or it may come into the bite. The patient tooth angle, the incisor edge may break. So in these cases, what I did is I had gone for a zenith correction. We have lasers in my clinic, so we did the laser correction of the zenith, and this is the patient's pre-operative. So the patient had a gummy smile proper because anatomic clone was not looking. We increase the zenith. Can you see this? This is a post-operative. This is completely composites. Entire canine to canine of composites. I've closed it and increased the zenith height, made the tooth look bigger, okay, longer, and the height which we have achieved by do it just a gingivectomy. What happens? It may impinge the biological weight that will cause the problems to occur. So you can see this nicely. I have increased the height and the smile. Can you see the smile line? Now it has exactly matched the smile line, and the smile line has completely improved. Okay, this is very, very important. Okay, so this is how the tooth has to be. You should understand the proportions. Okay, you're not just adding the composites. So this is another case where, say, this is also another case. Okay, this is another case where you can see a old patient. Okay, it's around in the mid 30s. So here you can't give a much of a lot of. You have to go for a mono shade or a dual shade. Okay, younger patients, tooth is slightly tilted. So here you can see a diastema. Okay, the diastema closure is itself, it is a 1 2 hours topic. So I have closed around documented cases of around 800 to 900 diastemas, and that some have a follow-up. So because I'm doing a clinical practice since 2004, it's been almost 21 years. So there are follow-ups of 10 to 12 years of diastema closures. So if you do it properly, diastemas can be done wonderfully. Here I have closed the diastemas. You can see this with the composites. Okay, nicely. You have to, here I have non-surgically recontoured the gingiva. Okay, by giving a gingival retraction and placing the composite and retracted. There is a rule. There is something called as, there is an article in Perio that is called as Tarno et al. There is a rule between the tip of the papilla to the crest of the bone. If it is a 5 mm, then you can modify or you can recontour. So here, see the case here. See, I nicely merged the gingiva. Can see this? This gingival contour is nicely came like this. And the midline is completely at the midline. I didn't shift it. I added both together in a diastema closure. It has to be, you have to do the preparation here, like a C, and inside also do a C, both the side. Okay. Then you'll have to add here, but your original angle has to be maintained. It's an illusion. Diastema closure has two steps in it. One is giving a illusion and closing the black triangle. If you just close like this, there will be a huge black triangle. Does not look good. And you have to give a, see, can you see this here? Okay. If you see here, this is the original angles. So that angle has to be maintained. That is exactly of the same of the previous one. So rest is adding is inside. So that is the reason tooth does not look bigger or a broader. Okay. So nicely you can see here, this angle maintained, the original angle is maintained. Okay. And this is one case I'll just show you again how we have done the corrections. Okay. This is again a smile. We have designed the smile. Okay. With the correction. Okay. This is after the finishing. Okay, finishing has to be perfect. This case, I have a follow-ups of around 4 to 5 years. Okay, this is another case. Okay, this we have done a quad tree. We use the quad-tree and corrected the zenith. Okay, there was a case here. This you can see this with the quad-tree. I'm increasing the zenith, understanding the biological width. But I have a full-time periodontist in my clinic. I have a clinic in Pune. So we have almost prosthodontist and periodontist and endodontist, periodontist. Everybody is a full timer. So we do a lot of multidisciplinary practice. So we always think from the patient's point of view. You understand the biological width, and periodontist will do the CLP sometimes if required. Otherwise, I myself will do. Okay, reduce everywhere. Okay, slightly. It should be just roughened. You should not reduce too much. If you reduce too much, what happens? Tooth, it is very difficult to seal it later. Okay, so this is how add little by little. Okay, see, then when you add it, so add little bit, so place the matrices in a such a way that it should go inside the papilla. Can you see that? So that papilla will get, so that nothing should be inside the papilla. Papilla has to have this, your matrix band should go inside and papilla should be placed. Okay, so that composite should not go inside the papilla. Your matrices should go inside the papilla. So if you go, the composite goes inside, what happens? There will be gingivitis. Papilla will be lost. Okay. So this is the finishing and polishing afterwards. So this is how the same case, which was a gummy smile, which has multiple teeth. Okay, this is another case. Patient came with in this, what was the problem here? Patient didn't have she was a dental student and she has gone for a ortho. That's ideally the plan A treatment here is distalization of the canine. Okay,